Hello everyone, and welcome to this podcast or series on Linac-Based Stereotactic Radiosurgery and Stereotactic Body Radiation Therapy. In this first part, we will be looking at the key components of SRS and SBRT. And so the learning objectives really are straightforward. We will first define what is SRS and what is stereotactic body radiation therapy. We will compare stereotactic radiosurgery with conventional radiation therapy, as well as we will walk our way down the list and end this conversation by looking at some of the complexities of stereotactic radiosurgery, as well as a review of some examples of accidents that have occurred in this particular context. And so the very first slide that we will talk about is what is. The very first question that I want to answer is what is stereotactic radiosurgery and what is stereotactic body radiation therapy? In simple terms, stereotactic radiosurgery are non-invasive techniques that precisely and accurately delivers large or highly conformal radiation doses to small intracranial targets. Now, typical targets include brain metastasis, you have acoustic neuromas, you have P33 adenomers, trigeminal neuroglias. These are all examples of intracranial targets that are typically targeted by stereotactic radiosurgery techniques. And we typically apply just a single fraction, and sometimes we do fractionated radiosurgery where we could give up to about 5 fractions. The next question on the list really is, what is stereotactic body radiation therapy? Some people prefer to call it stereotactic ablative radiation therapy. Now, SBRT, as we shall call it henceforth, typically is a very high precision, just like SRS, non-invasive, image-guided delivery of very high doses of radiation to small extracranial lesions. Typically, these lesions are localized, and we do this delivery in, from 1 to about 5 fractions. Several spinal cases, we typically give just a single fraction. Typically, for lung cancer cases, we do fractionate up to about 5 fractions. We will discuss this in detail in later parts. Now, this definition really is provided in AAPMTG 101, and that is really a good report for you to start off with. And so, what really stands out for both SRS and SBRT? Now, what you need to keep in mind is that the primary rationale for stereotactic radiosurgery and stereotactic body radiation therapy essentially is to deliver a significantly higher biological effective dose, which in turn improves the local tumor control by increasing the tumor control probability, and at the same time necessitates a steep dose gradient and very high conformality in order to decrease the normal tissue complication probabilities. In other words, in order to spare the surrounding healthy tissues and the surrounding critical structures. Which means that both SRS and SBRT are typically designed to provide a high biological effective dose to the tumor with a very steep decline in dose to the surrounding healthy tissues and critical structures. Unlike SRS that typically has about a single fraction, SBRT are delivered to extracranial lesions in 1 to 5 fractions. Now, the word stereotactic used in both cases originates from the Greek word, from a Greek word that means stereos, which actually means a solid, and thesis means order. Now, when we use the word stereotactic in this context, or that particular word stereotactic is typically used to define a three-dimensional localization of a point in space by a unique set of coordinates that corresponds to a fixed external reference frame. In other words, the word simply implies that we have the ability to localize our target within a three-dimensional space. And so, to summarize the term stereotactic, therefore, in this present context regarding Linac-based radiosurgery, refers to the target-centric nature of the process, which employs the use of online images to help in target localization. Now, with regards to SBRT, when we use the word body in this context, it simply implies that we are dealing with lesions or target outside of the brain, or we are dealing with extracranial target. But sometimes stereotactic radiosurgery, the phrase is used for spinal cases, I guess because the spine is part of the central nervous system, which is connected to the brain. So you need to watch out for how the term is being used interchangeably. And therefore, to end this particular slide, stereostacy is a central concept here, and therefore refers essentially to a procedure in which a point within the brain localized with the use of external fixed three-dimensional reference systems, such as a rigid head frame, that was initially used in neurosurgical procedures. And so when we look at stereotactic radiosurgery, SBRT versus 3D conformal radiation therapy, in other words, conventional radiation therapy, there are some significant differences. The very first that comes to mind is the fact that in stereotactic radiosurgery, we deliver very, very high doses, typically in the order of about 6 to about 30 gray, in very few fractions, typically 1 to 5 fractions. But in conventional radiation therapy, we deliver typically 1.8 gray to about 3 gray in between 10 to 30 fractions. This particular premise implies that how we go about conventional radiation therapy is remarkably different from how we go about stereotactic radiosurgery. Now, in terms of target definition, in both cases, we use ICRU 50 and 62, I think, to define our GTV, the gross tumor volume, to define our PTV, the planning target volume, and our CTV, the clinical target volume. Now, also keep in mind that, as we will discuss in the future in other parts, how the PTV margins are defined, typically for SRS cases, is really different from how they are defined for conventional cases. The basic premise for conventional radiation therapy is that the dose, a uniform dose, is delivered to the target, and at the same time we spare the surrounding organs at risk. But the fundamental premise in stereotactic procedures is the fact that we deliver a heterogeneous, the dose distribution within the target is not uniform but very heterogeneous, and this is actually encouraged because a higher dose is delivered to the core of the target that is hypothesized to have what we call hypoxic, highly resistant cells to radiation. Now, in terms of margins, like I did before, for conventional cases, the margins are in centimeters, but for stereotactic procedures or radiosurgery and SBRT, the margins are typically in millimeters. And sometimes we don't use any margins at all. And we are going to talk about it in details very soon in the future. When it comes to about the required set of accuracies, now in both cases, we primordially use MPPG9A for stereotactic procedures and TG142 as well as TG40. But for conventional radiation therapy, we use TG40 and TG142. And so the common intersection in this case is TG40, TG142, but specifically for SBRT, SRS, we have MPPG9A, we have TG101, we have TG142, and we have TG40. Now, what you need to keep in mind is regarding redundancy in geometrical verification. There is none for conventional fractionations or conventional radiation therapy, and yes, it's very much used in stereotactic radiosurgery. Now, regarding the need for motion management, now the application, it's moderately applied in conventional cases, but it is a must for stereotactic radiation surgery, and we will talk about motion management in one of the parts in this series. And yes, for radiobiologically, it's conventional radiation therapy is very well understood, but stereotactic procedures it's not very well understood. And so with regards to staff training, both conventional and stereotactic radiation therapy requires a high level of staff training. But when it comes to stereotactic radiosurgery, the therapists, the medical physicists, the oncologists need to undergo a special training for these procedures before they are being able to appropriately apply these procedures. And so to summarize this, the central characteristic that distinguishes SRS, SBRT from conventional radiation therapy is the use of small fields in very few fractions to deliver very high doses of radiations. Now, small fields in this context necessitates a very high precision during the delivery process, and it also necessitates a high degree of accuracy in target delineation as well as in the delineation of the surrounding organs at risk. And so what therefore distinguishes in terms of local control? So what actually distinguishes stereotactic radiosurgery and conventional radiation therapy in terms of local control is the fact that the BET in stereotactic radiosurgery is much higher, which improves local control, increases the tumor complication probability, and therefore decreases the NTCP as well as increases the sparing or improves the sparing of the surrounding organs at risk. And so to end this from AAPM TG101 says this, now that a must for stereotactic radiosurgery, especially stereotactic body radiation therapy, that it essentially the practice of SBRT requires a high level of confidence in the accuracy of the entire treatment delivery process, from CT simulations to treatment planning to treatment delivery. In order to assure this accuracy requires the integration of modern imaging technique throughout the entire treatment process from simulation to treatment delivery. From simulation to treatment delivery. And so this brings us then to the crucial part of this lesson or this talk, is what then are the key components to ensure that we deliver a high radiation dose that is very conformal with a very steep dose gradient in order to improve local control and also improve the sparing of the surrounding organs at risk. What are the essential things that are required to achieve this process? The very first, all of these are essential, which means that one is not more important than the other. So the order with which I discuss this really has no meaning here. They are all very essential. The absence of one means the failure of the entire process. And so to start from CT simulation, the very first, we need a robust immobilization system. So in order to ensure a high accuracy and precision in the delivery of stereotactic procedures implies that we need a robust immobilization system. Now, a robust immobilization system essentially ensures an accurate and a reproducible patient positioning throughout the entire treatment process, from CT simulation to treatment delivery. In other words, it ensures that we know where the target is and we are hitting the target every single fraction. Now, the next on the list is a multimodality imaging system. Take, for example, in intracranial cases where we are dealing with lesions within the brain. Now, MRI provides a good soft tissue contrast superior to CT scans. What this means essentially is that in order for us to appropriately and accurately delineate the target as well as the surrounding critical structures, we need to incorporate MRI into the treatment planning process. Therefore, this process really demands the integration of modern imaging systems, such as CT, MRI, PET-CT, typically used for lung and abdominal cases, to visualize and precisely delineate the target volume and the surrounding critical structures. Also, the third on the list that is absolutely very essential is the need for a very specialized treatment planning system. Now, the treatment planning system should have the capabilities of integrating information from various imaging modalities that can be used by the oncologist, the physicist, the dosimetrist to delineate the target, the surrounding OARs accurately, and to accurately simulate or calculate the dose distribution within the treated anatomy. An accurate dose calculations will give us a highly accurate conformal dose with steep dose gradients that we require in order to prevent the over-irradiation of the surrounding organs at risk. Now, the next thing that we need to be able to do, especially for abdominal and thoracic lesions, is to be able to quantify, to evaluate and quantify the degree of motion of both the target and the surrounding OARs. This means that we have to have the ability to use techniques such as 4D CT, breath hole, fluoroscopy, to be able to access or quantify the motion of tumors, and the surrounding OARs during simulation. And lastly, we should not just be able to quantify the motion of the target. We should have techniques in place that can manage motion during treatment delivery. Typical techniques that are used across the board, across different cancer centers around the world. You have the most common one is 4D CT. We're going to talk about this in quite some details in our part in motion management. You have abdominal compression. You have gating, tumor tracking. These are all techniques that can be used to manage tumor motion, during SBRT treatment to effectively, deliver a high conformal dose to the target and spare, the irradiation of the surrounding healthy tissues. And so the next question, which I think is a fair question to ask, really, what is the rationale behind SRS and SBRT? Now, TG101 actually provides some good bullet points or some good reasons why SBRT is offered. Now, I'm going to give you just quite a bit of a summary here, but if you need some details, I recommend that you should read TG101. It is really full of some really good, juicy information. Now, the very first reason, this is not found in TG101. The very first reason I call it here a radiobiological rationale for SRS and SBRT. This really looks at the way cells behave when they are irradiated. Now, several studies from animal and from tissue cultures essentially has demonstrated that when cells are from the time cells are first irradiated to about 3 weeks out, the tumor repopulation remains relatively zero or constant. What this implies is that during this period of about 2 to 3 weeks, the amount of radiation dose required to maintain a particular tumor control probability is relatively constant. We call this the delay period, as shown by this this graph here. This period we call this the delay period here, the delay time. On and about between the second and the third week, there is a T delay from which the cells begin to repopulate rapidly. And the rate of repopulation depends on what we call the K factor. Now, we are going to talk about this in detail in my upcoming series on how to deal with unplanned treatment or how to deal with unplanned interruptions during radiation therapy. Now, what this means is that accelerated repopulation, which is actually apparent in some tumors, typically occurs around the third week or 28 days after treatment. And this alters the K factor, which essentially is a factor that is used to determine the amount of radiation wasted because of tumor repopulation. And so the radiobiological rationale in this particular sense for SBRT is we typically deliver this technique in 1 to 5 fractions within 2 weeks, which is way in the time period within which cells are not rapidly dividing. And so this gives us a good window to ablate and sterilize the cells before accelerated repopulation begins. And I see it as a win-win for everybody. And so we are able to therefore deliver a higher biological effective dose within a period within which tumor repopulation is relatively stable or almost zero. Now, compared to conventional radiation therapy that typically spans up to about 30 fractions, we need to take into account the extra cells that are created after the third week. And especially this becomes really significant if the patient misses treatments especially in the last week of treatment. And we're going to talk about this in our future series. Now, the next rationale, which is offered in TG101, comes from what we call the theory of oligometastasis, the theory of oligometastasis. Now, oligometastatic disease typically is a type of metastasis that occurs in cancer cells in which cancer cells from the primary tumor or original tumor travel through the body but only form a limited number of metastatic tumors, typically 1 or 2. For example, let's say brain mets are typically originate from breast cancer, lung cancer, melanomas, and so on and so forth. And so let's say, for example, cancer cells that may spread from the breast, to nearby organs, such as the brain, the liver, and the spine. But if these cells are only limited to very few mets, maybe 1 or 2 mets, then we stand to reason that we need to aggressively pursue this very few oligometastatic disease to completely sterilize the cells from the body and heal the patient from the metastasis. The next rationale offered in TG101 is what we call the Norton-Simon hypothesis. The Norton-Simon hypothesis. Now, this hypothesis essentially states that the rate of growth of cancer cells, or the rate of cancer cell death in response to treatment, whether chemotherapy or radiation therapy, is directly proportional to the rate of tumor growth at the time of treatment. Is directly proportional to the rate of tumor growth at the time of treatment. Now, when you look at the NS curve, what you realize is that initially the rate of growth of cancer cell is typically initially very slow. The cells then hit an accelerated growth phase. Now, during the accelerated growth phase, the cells themselves are highly radiosensitive. And if the cells are highly radiosensitive when they are clinically dictated, we stand to believe that if we aggressively pursue these cells with ablative radiation doses, we can actually heal or cure the patient. But here's the kicker though. When the cells grow and when the tumor becomes large, especially given the fact that tumor vasculature is very primitive and very poor, the cells at the core or the center of the tumor becomes devoid of oxygen because of poor vasculature. Because they are short-circuited from the oxygen supply, they become hypoxic. Hypoxic cells have a tendency to become radioresistive. And so we stand to reason that if we can attack and kill the cells when they are still radiosensitive, then we stand a higher chance of actually healing the patient. Hence, SBRT becomes really, really appetizing. The complexities that we encounter in stereotactic radiosurgery. It is a highly specialized process in which we deliver high doses to small targets, and it is a complex process. So the question is, what really are these complexities? One of the unique things about stereotactic radiosurgery and stereotactic, body radiation therapy is the fact that the dose distribution for both techniques are characterized by a steep dose gradient. We know why it's important. We need to be able to spare the surrounding organs at risk. It is also characterized by high conformality, and also, as we will discuss in another part of this series, the dose distribution within the target itself is highly heterogeneous, and it is actually encouraged. Now, the high conformality to the PTV or the GTV, if we don't have a PTV, is crucial in order to increase the biological effective dose, which in turn increases the tumor control probability. In other words, this improves the local control. But here's the problem. In order for us to simulate an accurate dose distribution and produce a highly conformal dose distribution within our treatment planning system requires accurate beam parameters. And in order for us to get accurate beam parameters implies the accurate measurements of small field parameters such as depth dose curves or PDDs, beam profiles, output factors, and so on and so forth. And to be honest, the measurements of these parameters for small fields is very complicated. And so to summarize the factors that make SRS very complex, one, listen attentively, is the fact that we deliver these treatments in very small fractions, typically 1 to 5. What this means is that both setup uncertainties cannot average out as compared with conventional treatment. And because they cannot average out, there is absolutely no room for error. Secondly, we are delivering very high dose per fraction. In some cases, such as in trigeminal neuralgia, we deliver up to about 90 gray in a single fraction. And there is even situations in which we give up to about 140 gray in a single fraction. What this means is that the margin for error is nil. In other words, we must hit the target every time, and this necessitates high conformality and a steep dose gradient. The next complication comes with small fields. For SRS cases, the fields, the cones or the cone size can sometimes be as small as 4 millimeters. And for SRS, they're typically less than 5 cm. And small field dosimetry is practically complicated and must be accurate. Really must be accurate. The last thing is we need an accurate beam model to be able to simulate an accurate dose distribution within the the target or within the treated anatomy. And in order for us to get an accurate beam model so that our treatment planning system can calculate the dose distribution accurately, it requires the input of accurate beam parameters such as PDDs, beam profiles, output factors, and so on and so forth. And the measurements of these output factors for small fields is complicated, as you will clearly see. But the question, which I think is really legitimate for us to now ask and answer at this point, why do we have to worry about these complexities? The reason I think we need to absolutely be worried about these complexities is because detrimental accidents have occurred across the globe in the past that have harmed patients because of these complexities. And in the next few slides, I'm just going to share with you a little bit of these accidents that really have occurred in the past. Now, according to the World Health Organization radiation risk profile, the two most common sources of adverse events in radiation therapy are commissioning and treatment planning. Now, as a matter of fact, more than 98% of the accidents that have occurred throughout the history of radiation therapy really have been throughout the history of modern radiation therapy have been due to commissioning and planning, and all of these related to small field measurements. And so commissioning errors typically are that have been reported. You have small field measurements, small field absolute dose calibrations. Treatment planning errors include things like using the wrong cones or treating the wrong sites and stuff like that. In this example here on the slide, there are actually quite a couple. Now, in Cox Health, which is or was a hospital in Springfield, they actually accidentally over irradiated about 76 patients, most of whom were actually treated for intracranial stereotactic procedures. Now, these patients essentially were overdosed because of errors in the measurements of small field output factors. In another accident that was reported in Morphead Cancer Center in Florida, patients really were still over irradiated to the tune of about 50%, and they were attributed to calibration errors during commissioning. And we can go on and on. In France, about 145 patients were affected. Still, they were overdosed. And in this particular case, still the measurements of small field output factors was done with the wrong dictator. And we are going to talk about this in small field dosimetry, all about volume averaging. Using the wrong dictator size to measure output factors underestimates the output factors, as you can clearly see on the graph right here, where the Farmer's chamber was used to measure the output factors. The underestimation of the output factors implies that in order to compensate for this, the Linac will actually overestimate the number of the monitor units that are going to be delivered, and so this will lead to the over irradiation of patients. And so small field dosimetry is important, and it is absolutely critical as medical physicists, radiation oncologists, and dosimetrists, as well as therapists, to be cognizant of these incidents that have occurred and to take the appropriate steps to prevent these incidents from happening again. It is our duty to keep our patients safe at all times. Thank you. I appreciate you staying tuned for this presentation. The next part of this presentation, we will look at some aspects of small field dosimetry. Stay blessed and stay tuned. I am Kimal Onojam, and medical physics is my passion. Thank you. Bye-bye.